Begin. So good evening and welcome to AmSECT's educational webinar, 60 minutes on ECMO cannulation, a perfusionist perspective. This is the first of a series of ECMO education webinars offered by AmSECT and will occur approximately every 1 to 2 months. I'm Bill Dubois. I'm AmSECT president and a director in peri-op services at New York Presbyterian Hospital, Weill Cornell Medical Center. And I'm happy to be joined this evening by Desiree Bonadonna, ECLS Director at Duke University Health System, Dana Mullen, Chief of Clinical Perfusion and ECMO Services and Education at New York Presbyterian Hospital, Columbia University Medical Center, and Dr. Corey Allworth, Chief of Cardiovascular Perfusion and Assistant Professor of Surgery at the Mayo Clinic in Arizona. This is a great opportunity to learn about cannulation strategies and many other more techniques in ECLS therapies, as this group has experience with over 600 ECMO procedures annually. Again, thank you for joining this evening. Also like to thank President of ELSO, Dr. Mark Agino, he's supposed to be on tonight, and Logistics and Education Committee Chair, Dr. Bishoy Zachary. Thank you, doctors, for joining us on our ECMO Focus webinar. Again, we have over 600 guests tonight, so we may not get to all the questions that you have, but we'll tell you some of the matters on that later. The format of tonight's webinar is a brief introduction, followed by a 20-minute presentation by Desiree Bonadonna, then a panel discussion, and then a question and answer period. Again, we will conclude the webinar after 60 minutes. This webinar has been approved by the American Board of Cardiovascular Perfusion for 1.2 Category 1 continuing education units. To claim your credits, you will need to complete a brief evaluation that will be emailed out to all participants after the conclusion of this webinar. There will also be an evaluation to provide you with the ability to submit future webinar topics or suggestions for this continuing education. Again, during the webinar, you will be muted, but please feel free to type in questions using the question and answer feature on the bottom toolbar provided by Zoom. Again, it's located at the bottom of your screen. Questions should be specific to cannulation techniques, because again, we will be offering other educational topics on ECMO in upcoming webinars. Names of those asking questions will be kept anonymous. And remember, we won't be able to get to all of the questions, but we will post many of them within a week or so on the AmSECT website, along with the video of this webinar. Again, thank you for joining us. I'd like to present our first presenter, Desiree Bonadonna.
Thanks, Bill. See if we get the presentation up there. Can you see the presentation, Bill?
I do not.
I don't see it.
I see it up.
Great.
Okay.
All right. So as Bill had told you, we are discussing today cannulation strategies for ECMO. And this is a compilation of all of our works, but in 20 minutes, we're going to just kind of scratch the surface here. So we don't have any relevant financial disclosures from this group pertaining to this talk, and we are discussing the off-label use of FDA-approved devices. So something that we did want to discuss prior to discussing how we're actually cannulating the patients is that we're trying to standardize how we're naming an ECMO configuration. And so what we want to do is use the hyphen to act as the oxygenator. So whatever we're naming pre-oxygenator would be pre-hyphen, and whatever is occurring post-oxygenator would be post-hyphen. So for example, VVA ECMO or VAV ECMO would be hybrid ECMO with one venous drainage and then 2 return cannulas, one to a vein and the other to an artery. Some are suggesting that for every cannula, you would also add another letter to the naming of the ECMO. Not everyone agrees with that. And this is published in Critical Care this year. So typically we're cannulating for VA ECMO for cardiogenic shock patients and cardiopulmonary failure patients, and VV ECMO for respiratory failure and our septic shock patients, with hybrid ECMO being used for cardiac recovery and persistent respiratory failure patients, or respiratory patients requiring partial ventricular unloading or support. When looking at VV ECMO, choosing a cannulation strategy for respiratory failure, if we want our patients awake and rehabilitating, we often go for a single site dual lumen catheter. However, in acute disease processes such as ARDS and septic shock, we're looking more at our FEM-IJ and FEM-FEM VV ECMO approaches. This diagram shows where those cannulas would be located, usually draining from the femoral vein, which is parked behind the liver, and returning oxygenated blood to the right IJ, hopefully directing that bloodstream towards the tricuspid valve and the patient's circulation. The other usual configuration would be a short venous catheter draining from one femoral vein and a longer venous catheter directed up into the right atrium to return the oxygenated blood. We also have dual lumen catheters inserted usually in the right IJ, sometimes the left subclavian, and sometimes the left IJ, which has drainage ports in the IVC and SVC and returning the oxygenated blood to the right atrium. Show x-rays here of left subclavian cannulation on the bottom right and right IJ cannulation of a double lumen catheter on the top left, and showing that if positioned properly, the oxygenated blood from your VV ECMO circuit would be directed towards your tricuspid valve. This is showing very similar, but a different brand of the catheter, and this is being inserted via the left subclavian. This x-ray is showing the FEM-FEM VV ECMO approach. On the right side of the picture, you can see the multi-stage femoral venous drainage catheter. And then extending beyond that is our return catheter, or our ECMO outflow, being directed towards the right atrium. One thing we have struggled with, some of our taller patients, is getting this all the way up to the right atrium to avoid recirculation. Comparing our approaches, FEM-IJ for VV ECMO is very easy to insert. You really don't need much imaging to get it in the right place. It's rather low risk. You can get very high flows. You do have to use 2 sites, however, and you do have limited mobility of your leg and your neck, which is a limitation for some of our patients for physical therapy. The FEM-FEM approach, placement is critical to make sure that we avoid recirculation. Imaging is usually preferred, if not required. It takes up a lot of real estate in your groins. You can get a lot of flow. However, you do get quite a bit of mixing as you're not capturing that upper body venous drainage very well. And you're at higher risk for recirculation if you don't get those cannulae in the proper positions. It's a great option though for patients that have upper body anomalies or upper body trauma, patients who have had a lot of upper body catheters placed previously. And we like to use it in our lung transplant patients because the groins are already prepped into the field. Your dual lumen catheters require some imaging, and different centers have different approaches for how they do that, whether it be TEE, transthoracic echo, fluoroscopy, or ultrasound. It is associated with risk during the cannulation procedure, which has been documented in the literature. However, you're able to use a single site, and this could enhance patient mobility, particularly with the left subclavian approach. Patients seem to find that the most comfortable and the most able to move their neck around, participate in physical therapy, and ambulate. We have noticed lower flows in our dual lumen VV ECMO patients compared to the other approaches. Moving towards VA ECMO, you have a number of options. Your centrally cannulated patients. You can use a carotid artery or internal jugular vein, which is typically reserved for our neonatal and pediatric population. However, there are some adult programs using that strategy. You can do an end-to-side graft to the axillary artery for your arterialized return blood, or a FEM-FEM approach, which is probably the most common in emergent situations outside of the operating room. One algorithm for choosing how to cannulate a VA ECMO patient is whether or not they're stable to move to the OR. You discuss if they've had a recent sternotomy and if that should be reopened. If they have, a lot of programs will go towards central cannulation, but there's discussion about the increased risk of sternal infection. And if you start with peripheral cannulation and you're noticing any limb ischemia or inadequate LV decompression, after you've exhausted your peripheral LV decompression methods, you may move to central cannulation as well. Some programs will take patients who are high risk for limb ischemia and go directly to central cannulation. Reviewing our femoral vessel anatomy so that you can see where your femoral veins are located in relation to the inguinal ligament and where your superficial femoral artery is, which is typically cannulated for distal perfusion catheters, which we'll discuss. Disadvantages to femoral artery cannulation. There is an associated increased risk of infection. There's LV distension possibilities, which would limit your LV recovery as you're adding afterload of that retrograde flow, which would result in pulmonary edema and possible pulmonary injury. There's potentially an increased risk of stroke with retrograde flow, and there's an increased risk of limb ischemia. In some papers, that's reported up to 52% of their patient populations. Surgical interventions reported up to 22% and amputation up to 10% of femorally cannulated patients. Some ways to help mitigate cannulation complications for our femorally cannulated VA ECMO patients include making sure that we're not injuring vessels during introduction of the catheters and use of ultrasound guidance and placing of a distal perfusion catheter. The distal perfusion catheter will provide antegrade blood flow down the leg. Another method would be to use a graft instead of a cannula so that blood can flow both up and down the leg, avoiding potential femoral ischemia. Often, patients are cannulated quickly. There's not time to sew a graft onto their femoral vessels. So we will cannulate a patient, and this is one technique where they leave the femoral cannula in and band the vessel and begin sewing the femoral graft and then move the cannulation through the graft. Other centers will cannulate and then move to the other femoral artery on the other leg instead. To share our experience, from 2009 to 2014, we had noticed a nearly 30% vascular complication rate. When we processed this data, we began using femoral cut down for our ECPR patients to help avoid some of the vascular injury we were noting, and we routinely placed distal perfusion catheters at that time. In 2017, we began using graft cannulation for elective VA ECMO femoral cannulation patients. And in 2017, we got our vascular complication rate down to 9.4%, noting that 50% of those complications were occurring in our transferred patients. In 2018, 5.3% vascular complication rate with ongoing education of our own institution, and 75% of those complications were occurring in our transferred patients. So we took on efforts to collaborate with our referring hospitals, and we were very happy to announce that in the last quarter of 2018, we had 0 vascular complications, which we're hoping to maintain with our approach. Our approach is not the only way to do it. We do place a distal perfusion catheter at the time of cannulation, or we graft cannulate all of our patients. We do Q1 hour pulses, and if we can't find a palpable pulse, we will use Doppler. And we consult vascular surgery and we recannulate these patients early if we're having any difficulties. The approach from New York Presby Columbia is slightly different. They only place their distal perfusion catheter as needed. The monitoring is performed by ICU staff and the perfusion team, and they're looking for mottled skin, cold limbs, and they're Dopplering every 2 hours. They also use the CASMED NIRS technology, and they're looking for tissue saturations less than 50% before they intervene. Another disadvantage to peripheral cannulation is LV ejection in the setting of pulmonary failure, resulting in north-south syndrome or Harlequin syndrome. This is where hypoxic blood is perfusing your coronary vessels and your carotids, because your lungs may not be performing as well as they need to have all of that blood flow through them. So as your heart is ejecting, you're ejecting the hypoxic blood. One solution for this is a VAV, ECMO cannulation strategy, where you're pre-oxygenating the blood going through the heart and the pulmonary vasculature. We monitor all of our femoral patients on the right arm, and we test our blood gases from our right radial site so that we can best approximate coronary blood flow oxygenation. We can also improve RV drainage to unload the heart and remove the blood going through the pulmonary vasculature and then the hypoxic blood being perfused to the coronaries and the cerebral vasculature by adding more cannulas, hoping to improve flow while pulling off volume of our patients. Another strategy is to move towards central cannulation plus or minus an LV vent. One of those options is a subclavian artery cannulation. This does offer the patient a little bit more mobility, and it will help with some of the root and brain perfusion issues that we were seeing with our femorally cannulated patients. It does have a 15% complication rate, most often reporting as bleeding. We do still have some persistent coronary ischemia in our patients with poor respiratory function. And there is risk for brachial plexus injury, especially hematomas applying pressure in the site. And there's a risk for arm hyperperfusion. Another strategy is moving towards the ECMO sport model that has been well described, where it is completely upper body cannulated. Similar complication rates, obviously, and this is unfortunately one of the results that can be seen when we hyperperfuse our arm from the subclavian artery cannulation. So we do monitor our pressures in our right arm and our left arm for these patients. Another option is to, again, use that subclavian site, but using a dual lumen catheter and providing VAV ECMO support. This is great for patients with pulmonary hypertension that have respiratory dysfunction and some right heart dysfunction. Another option is to go to an ambulatory central cannulation technique where you're tunneling the cannulas to get patients up and walking, essentially on bypass. It's important to consider ventricular decompression in patients with very poor ventricular function. Your options include surgical vent placement, impella unloading, and using a balloon pump. Another option is to directly cannulate the RA, the aorta, and place an LV vent. And this can be done via a very small thoracotomy in the right second intercostal space. And this does allow complete unloading of the patient. It avoids a sternotomy, and it allows the patient to comfortably walk and participate in physical therapy. This is showing the x-ray of what that looks like and what the incision looks like after closed, which is quite impressive to have complete support and unloading and be able to get these patients up and walking around. For our femorally cannulated patients and patients that we do not wish to do a thoracotomy or sternotomy on for various reasons, there is the placement of an impella for unloading in our ECMO patients, going over the various options for your impella insertion sites. We typically steer clear of the 2.5 in this area and go more towards the CP. It has been described that it is advantageous in unloading in our ECLS patient population and can in fact improve 30-day mortality. Another option, and this is typically reserved for patients who have already had a balloon pump in place and just leaving the balloon pump in place, because it can assist with unloading, but it is not the most efficient means. And this graph shows that the impella with VA ECMO is actually the most efficient means of unloading our patients who need ventricular decompression. For our patients with persistent right heart failure, there are a few options. We can do central cannulation, we can do peripheral cannulation, or we can use one of the Impella devices, the Impella RP. The benefit to using the centrifugal pumps that are external would be that you can add an oxygenator for what we like to call RECMO. This is just one diagram of how the ProTech Duo sits in the pulmonary artery, and in this picture they have used an oxygenator and are providing right ventricular support as well as respiratory support. When things get a little more complicated and we need source control for lungs, we can get pretty creative with our cannulation techniques and support any situation, such as removing infected lungs while waiting transplant. This is the publication from Toronto, where they removed the lungs from the patient, and they have flow from the right ventricle to the aorta in a standard VA ECMO circuit, and then the residual flow passing from the right atrium to the pulmonary artery is shunted and oxygenated via the Nova lung. And this patient was supported and successfully transplanted this way. Another method, we didn't have the Nova lung available to us, and we needed to get source control for a patient for bridge to lung transplant. So we anastomosed the PA to the LA, and that allowed some flow from the right ventricle over to the left side of the heart after the bilateral pneumonectomy. And we bicavally cannulated the patient for drainage to our ECMO circuit. Then we returned some of the blood to the pulmonary artery and the remaining blood to the central circulation. We chose this configuration to make sure that the ventricles remained somewhat loaded with no stagnant areas. And we were able to control the flow between the RA and the aorta with a Hoffman clamp. So in conclusion, the indications and contraindications for adult ECMO are dynamic, they're evolving, and novel cannulation strategies can support patients that we previously thought were unsalvageable. Careful consideration and often revision of cannulation strategies may reduce some of these potential complications that we've seen. I think at this time we are opening up for questions. I'm gonna hand it over to Bill.
Yes, thank you, Desiree, very nice.
Thanks.
With some of our other panelists, Dana, you have experience with ECMO education specifically. One of the questions was about small cannulas to start ECMO. How do you do that, and what's your training? Education for staff. Do you use much in the line of simulation, high fidelity simulation?
Okay, thanks, Bill. So as far as smaller cannulas, we typically start out with small cannulas for VA ECMO. Typically our standard cannulation strategy, if we use percutaneous cannulation, is a 23 French biomedicus venous and a 15 French femoral biomedicus in the femoral artery. And we do this because most of our VA ECMO, we do not provide full support. We do still want blood to move through the native cardiac circuit. We want the heart to eject if it's ejecting to prevent stagnation or clot formation. And if we have to unload, we will put an Impella in, or we will put an LV vent in. Choosing a smaller femoral, in the past, we've used, largest cannulas possible. And in our experience, we have lost limbs or had limb ischemia. And we transitioned to now this smaller cannula approach. And we do use the foresight, the mirrors on the calves. We do not put a DPC in right from the start of every cannulation. And we monitor these values along, Desiree mentioned that along with clinical assessment of pulse checks or Doppler checks every Q2, we now do checks every hour. The nurses will check hourly. And we also increased our limit, our threshold for escalation. It used to be if the saturation dropped below 50%, we would escalate it. But now we actually increase that to 60%. If the value drops below 60, along with a loss in pedal pulse or a loss in Doppler, that is an indication for a distal perfusion cannula insertion. So with the smaller cannula, that definitely has helped and decreased the amount of distal perfusion cannulas that we are inserting. As far as staff training, right now we are training all disciplines that are involved with taking care of managing a patient on ECMO: nurses, physicians, nurse practitioners, the perfusionists who come for simulation. And we really focus on troubleshooting and recognizing scenarios and how to so we have a faster response and patient care. So that's typically what we do at our Center for Education. I'm not sure if anyone else wants to add anything as far as what they do, if they use simulation as well.
Well, actually, there's a follow-up with that question. With training of staff, sometimes the cardiac surgeons can be overwhelmed. Have you moved to general surgery or cardiology, cannulating?
So cardiology definitely has started cannulating down in the cath lab. Our surgeons still do support them. So they will, a fellow or a resident will come down and help assist at this time. But as far as anyone else, I think someone mentioned something, other physicians in other areas, like in the ED, we do not have any other physicians at this time cannulating patients onto ECMO besides CT surgery, fellow or residents, or cardiologists, interventional cardiologists.
Right. And actually, Desiree or Dana, one of the question was some common techniques for achieving LV decompression. Dana, you mentioned inserting a vent. What would be the technique for that?
So usually if it's a heart failure patient or a patient in cardiogenic shock or ECPR that requires LV venting, I'm pretty sure like a red flag is, we use a lot of SWAN monitoring on these patients. And if the PAD is greater than 18 or 20, that is an indication for inserting some sort of vent. Usually we will move to an Impella insertion to offload the left ventricle. If it's a surgical patient or the patient is a bridge to possible VAD, then a lot of times we will reconfigure the ECMO circuit and we will add a cannula into the left ventricle and we'll wire that into the drainage line. So then we'll drain from the femoral venous, let's say, drain from the left ventricle, and then reinfuse back into the arterial system. Okay,
and here's one with the VAV, the hybrid model, Desiree. How would you you'd cannulate the pulmonary artery?
No, so usually for VAV, depending how the patient started. So I know we're trying to standardize all of the naming. We usually kind of call it whatever we started with. So if we started with VV, it'd be VVA. If we started with VA, we say VAV. But if we're on VA ECMO femorally, and we needed to have some of that pre-oxygenated flow through the heart and lungs, we would usually just add a right IJ. So that would be outflow from the oxygenator, split to the femoral artery and to the right IJ.
Okay. Corey, one question, I guess you could answer this best. With the Harlequin syndrome, does the graft, because you've also discussed graft to the femoral artery technique, does that help avoid that complication, or?
Meaning direct cannulation with a graft in terms of Harlequin syndrome?
Yeah.
I don't think the two are related really. I think using either technique, I think you often fight Harlequin syndrome. Although I would like to comment a little more and compare my experience with Desiree's. She had shown some data on their distal or their cannulation techniques when they use a graft versus distal perfusion cannula and such. We actually made a concerted effort about, 6 or 7 years ago. We used to always use a distal perfusion cannula, and we switched to almost 100% graft so not directly cannulating the artery, but cannulating the graft. And we tried to publish our experience, or we tried to research our experience, and we couldn't really find a good answer for whether it was minimizing complications. Our problem was, first of all, a lot of times patients have devices in the other limb. They'll have like an Impella or a balloon pump in the other limb, so it's hard to isolate the effect of the cannulation technique for ECMO. The other issue is sometimes we would find complications in non-cannulated limbs. So, we might be cannulated on the right leg and throw a clot to our left leg, causing a complication there. So our data wasn't really clean, but subjectively, we're not sure it made a big difference in terms of complications. Although our surgeons still do like the technique because they don't have to do a vessel repair at the end. They can just staple the graft off and pull the cannula out. But in terms of your question directly related to Harlequin syndrome, I don't think there's a correlation there between the techniques.
Okay, good, thank you. Desiree, you mentioned a big drop in complications from, 30% down to 5%.
Mm-hmm.
I guess this question came out for ECPR. Is the preferred technique percutaneous or open?
So here we have moved towards all open if we're doing chest compressions on the patient and they don't already have access.
Wow.
For our patients in the cath lab that already have access, of course, we're just going to use the access we have and wire. But if we're doing chest compressions in the ED, we have gone to cut down. But I know plenty of centers that using ultrasound have had great success with just percutaneous cannulation.
Okay, thank you. Some of the questions are about the presentation. Will we get copies? Yes, that we will. One is more specific about the venting. What size cannula would you be using for that if you tried to directly vent the LV?
It depends on what it depends on the size of the patient and what the surgeon requests. We just had one not too long ago. I think we used a 28 malleable cannula.
Okay, and question, do you find for the panel less of an issue with distal limb ischemia when you do ipsilateral versus contralateral? So same side cannulation versus opposite leg cannulation.
In our experience, oh, sorry, go ahead.
No, please, go ahead, Dana.
In our experience, usually the leg with ischemia is the leg with the reinfusion cannula in it, in the femoral artery. It's not often that we see leg ischemia in the opposite leg. That's just our experience.
Bill, if I can just comment on that real quick.
Sure.
Because I've heard our surgeons and some other physicians and folks that I work with have a debate on this. And I think your question, if I understood it correctly, was, do you put both cannula on the same limb or do you separate them and do them on opposite limbs?
Yes.
And there's two theories that I've heard argued back and forth, although I don't have any data to say that one is better than the other. One theory is that we think we're going to probably have limb complications, so we would like to keep one limb free of complications. So you might put both cannula on one side, hoping to at least preserve one limb. The other philosophy or theory is that if you cause minimal damage to both, hopefully you can preserve both limbs. So I don't know if there's any research out there to say that one is better, but those are the two philosophies I've heard.
Okay. One with the smaller cannulas, what is the maximum pressures you'd allow? I guess your venous cannula is typically larger, but on the arterial side, if you do monitor pressure, and that's another question, do you monitor pressure? And how high would you let it go before you may take an intervention?
So our soft limit is 300 on our reinfusion side, but we do run ECMO with it higher than 300. But it just really kind of depends. Our high limit for drainage pressure is we use the cardio help, so we have negative pressures as well as both positive pressures. But we'll set our limit for -100. But certainly we have, run ECMO with, increased negative pressures higher than -100. But just there's other things associated with it, increased hemolysis, shear, stress on the cells. So those are kind of our soft limits.
Yeah, we use the exact same limits at Mayo Clinic in Arizona. 300 and 100 are kind of our general cutoffs, but like she said, we will push that if we have to.
Very nice. Here's one. If when weaning from ECMO, how long of a period do you allow before cannulating, removing cannula or recirculating circuit or even infusing blood volume? What's the longest you go, and what kind of anticoagulation technique do you do when you're weaning from ECMO?
I'll start. So we typically will not let our adult patients sit below 500 cc's a minute for very long. That's usually just while we are doing our echo examination. And we do not clamp and heparin flush our cannulas and leave them. We remove them immediately. We usually give a bolus of heparin right before our wean trial for our adult patients because we don't have a bridge in our circuit. But for our pediatric patients, we will clamp and flash for as long as it takes for us to feel comfortable for decannulation.
And here's one. When using on a VV that may be converted to VA, would you consider using a cannula such as the dual lumen Avalon as your total venous drainage?
No, never.
Never. Okay.
So we have in the past, and it's not a good experience. Usually, what we have experienced is that the membrane in between the dual lumens collapses, and
Yes.
one whole side completely clots off anyway.
It does every single time.
So
So
typically you'll have a N of 1 after something like that, right?
Yes.
Doesn't take much. Okay, a lot of questions about that. What do you think there'll be any increased availability of FDA-approved ECMO ECLS hardware within the next 5 years?
Rumor has it.
So related to cannula, let's say.
I can't speak on that. I mean, I know that there's some vendors out there that are trying to make a push, but I don't have any specifics.
And here's one. If ECMO cannula are not coated with anticoagulation or heparin, why don't they clot off?
Transit time, I would presume.
Well, I
The
think
blood doesn't
sometimes
tend
we
to
don't
be
know. Oh, sorry. Sometimes we don't know if they're clotting off. There have been reports of thromboembolic events shortly after removal of cannula. So that may be occurring. What's the best way, if you can again, what's the best ways to assess limb perfusion? I know it was discussed, but that'd be a nice review. Good techniques. And are there differences in the oximetry devices?
So for limb ischemia, how we assess, our nurses monitor the lower extremity, pulse checks hourly. If there's no pulse, then they'll do Doppler checks hourly. Check the skin, is it mottled, is it warm? And for us, we do put the NIRS saturation pads on the calves, and we'll monitor those values. If they drop below 60, along with clinical assessment, could be an indication for an insertion of a distal perfusion cannula. As far as the devices, the NIRS Foresight is said to be a superior device because you don't need to get a baseline saturation. I know with the Somanetics, you're supposed to get a baseline before you probably initiate ECMO flow. And then a lot of times that's a challenge, is to getting those pads on before cannulas go in, especially in an ECPR situation. But I mean, I certainly think that something is better than nothing. So I think that there certainly is value in using, you know, putting the somatic pads on the calves as well.
Very nice. Dana, you had mentioned the use of small cannula and a high pressure. I know many people wouldn't use a cannula with we learn in school, a pressure gradient, line pressure of 300. So that's kind of a surprise that you can go a month with something like that. What are some other surprises in your ECMO experience, or any of the panelists, that kind of fly contrary to what you initially believed or learned in school? Some
I think I can start if you don't mind.
Sure.
I think one surprise that we've encountered that I didn't expect to, you know, you hear all about hybrid ECMO, and Desiree talked about it during her presentation. We have not had good experience with hybrid ECMO. So if you think of hybrid ECMO as essentially VA ECMO and then stealing some forward flow to send to the right atrium, we have found that we're most often limited by venous drainage, so our total flow can't really change much because of that limitation. So in order to do hybrid ECMO, we have to minimize our VA ECMO in order to steal blood to send to the right atrium.
Oh.
And we found every time we do hybrid ECMO, we find that we end up converting back to true VA ECMO because we just can't afford to steal blood to send it to the right atrium. I'm not sure if Dana or Desiree has experienced that as well, but we thought we were being brilliant and trying to make it happen and then just converted back.
So for us, we've really only tried to go from VA to the VA-V ECMO when the patient does have really good ejection. And so I think that might be, and usually it's kind of in the process of converting towards VV ECMO for us. It's not necessarily a full support, because you're right, you cannot, if you have the same venous drainage catheter, you can't flow anymore, you're still limited by that. We have had instances where we needed a lot of flow and we needed that oxygenation, but we didn't have adequate ejection, where we've added additional drainage as well.
Okay, very nice. Well, it was mentioned that sometimes left subclavian access is used for a DLVV cannulation. Is this the Avalon cannula? Do you find it difficult to position it optimally for all patients, or does that cannula length of 30 centimeters seem too long or long enough for most patients?
So we haven't had any issues with the left subclavian. Usually it's the 27 or 31 Avalon that we're using, or the larger two sizes of the Crescent for that. Can't really say we've had any difficulty getting it into position for our patients.
Okay. One question was, initially when we were trained on ECMO, negative pressures were between 40 to 60 were acceptable. Now, panelists mentioned as high as 100. What led you to accept those higher pressures?
I'll take it. So first off, we are now measuring our venous or negative pressure in a different location than we once were. At one time we had better bladders. We did a lot of things differently. So now where the CardioHealth measures it is right at the inlet of the pump. So I would expect that to be very negative. But we use it more as a trending device. We ran years without measuring pressures. And so you didn't know what they were until you started losing flow on centrifugal pumps. And now we trend it and use it in our troubleshooting algorithm for managing our patients. And we also make sure that everyone understands what cannula you have and what kind of flows you can actually expect for that cannula. So if what you're trying to do makes sense for that cannula and you have no other choice but to try to continue at that flow, then you need to start looking at, do we need to recannulate this patient in a different way? Giving volume if your cannula is not big enough is not going to fix your problem.
One is on distal perfusion. They enjoy the presentation. Thank you very much. How do you monitor the flow? Do you actually measure flow in your distal perfusion cannulas, or do you just go by the indications of adequate perfusion?
I think Dana measures flow, correct? We do if we have a 1/4-inch tubing line going from our arterial cannula to our distal perfusion catheter. For a while, the surgeons were using pediatric cannulas as our distal perfusion catheters as well, which made that even easier to monitor for us. But we do not. We inspect, look at the flow, feel it and make sure it's warm, and just verify that there's flow through it and that we're getting the signals, which is not perfect.
Bill, can I add to that?
Yeah, sure.
If you have the capability to monitor flow on your distal perfusion cannula, then that's a really great idea. We set a threshold, so a high limit and a low limit, because a lot of times one way that we can, management for distal perfusion cannulas, if your tissue saturation, if on your oximeter drops, and along with the flow, then that could be an indication that you're clotting off your distal perfusion cannula or your line. And also, we rely on that when we insert a distal perfusion cannula, we look at that saturation, that it immediately increases, telling us that we are now perfusing the leg. We've had experience where once we inserted the distal perfusion cannula, the saturations do not go up. And the flow actually, we get a flow probe on, and the flow is actually higher than we expect. So typically, we see flow 100 cc's to about 500 cc's. So if your saturation did not go up and your flow was higher than you expected, that could mean that you are not in the right spot. And what has happened on a couple of occasions, or if we have transported a patient from an outside facility, we've seen a couple of times that the distal perfusion cannula actually went through the artery and is in the vein. And
Wow.
so you have higher flows because you're in the venous system, and your saturation would not increase because you're not perfusing the leg. So we do rely on flow quite a bit for our distal perfusion.
Very nice. Anyone else on that? There's some more questions we can get to.
Bill, just
Go
real
ahead.
quick, if I understood right, part of your question may have been aimed at just the technical technique to measure it.
Yes.
What we've done on occasion when we use a distal perfusion cannula is once an hour or so, we will have the ECMO specialist move the flow probe, pre and post distal perfusion cannula, and then you can take the difference, and you know that that's going down the distal perfusion cannula.
Here's a question on extremely large patients, obese patients. Any special considerations? Considering percutaneous, avoidance of percutaneous cannulation, not oversizing cannula, without cardiac output desired may not be required.
So we use
You know,
ideal body weight. I don't know what you do, Corey.
Ideal
No, go ahead.
body weight.
Oh, so we use ideal body weight when we're calculating flows. So for your obese patient, we wouldn't size our cannulas, but it is a challenge. It's a technical challenge. And while we won't say high BMI is a contraindication until they're in the BMI of 50 or up range, if they are not candidates for transplant and it's end-stage disease, obviously you wouldn't cannulate those patients. And usually that high of a BMI would be a contraindication for transplant in itself.
Nice. This has to do
Corey
with,
had something.
go ahead.
I was just going to say there's actually some research out that's starting to come out that says obesity actually has a protective effect, particularly in ARDS. And I'm not sure the mechanism is fully understood yet, but it seems that obese people might actually have some advantage during VV ECMO.
We think that those patients probably are not being ventilated enough. And so putting them on ECMO, we're able to take care of their respiratory function until their disease process heals. So those patients actually do really well.
Okay, here's one with ambulation. How often are you ambulating femoral VA cannulated patients? And are you ambulating femoral VA patients that may have an LV vent?
We have, and we are working on guidelines to sort of start doing this more often. But we typically ambulate more of we do ambulate femoral cannulated VV patients waiting for lung transplant. And we have ambulated on a treadmill in the patient's room, VA femoral cannulation. But we don't typically do it on a routine basis. It really depends, I guess, on a lot of things. And we're right now we're in the process of establishing some sort of guidelines, and everyone is collaborating on all PT, physicians and everyone right now trying to work on more a standardized approach for this. I don't know if Desiree or if Corey, if you guys do this on a.
So we went through the effort and gathered all of the disciplines to come up with our guidelines for ambulating VA, femoral VA ECMO patients. We haven't had a patient that was a good candidate that has required it yet. So we're going to be calling Dana for experience.
Okay. Here's one. Our typical experience with ECMO are patients lying flat in bed and not ambulating. What differences should I expect when we move to ambulating patients? Like cardiac output, it seems that might be something that could change. Venous pooling, are they any kind of changes you've seen with your ambulatory patients?
For us, it's a very slow, gradual process. I know PT or OT will start out with just, raising the bed up first and having them sit up. And then it moves to the edge of the bed and dangling their feet. It's like a very slow progression, and it's up to the patient how they feel. And then eventually we will get to standing in place. And some of our experience, yes, they do sometimes get orthostatic, dizzy, don't feel well, need to sit down. In some situations, we've had to move a patient to a chair and actually give them some fluids before we would get them up to start and start walking, and that has helped. But it is a very slow process, or stepped process to getting them. We don't just take a flat patient and then just get them out of bed all in one day.
Yes. Okay, this is very nice. I'm firing away the questions and keep firing back the answers. Here's one. Does anyone use an AV bridge? If not, why not?
We do for pediatric patients, but not our adults or all the standard cardio help or just a rotoflow and oxygenator and arterial and venous line.
Desiree, you said for pediatric patients you do, adults you do not?
Yeah, pediatric patients 20 kilos and less, we have an AV bridge for their weaning process.
And where is that positioned?
It's actually back towards the circuit, which is a change since we went to the cardio help, because we wanted to minimize our connectors. So our 3/8 quarter-inch connector has the connections for our bridge.
And Corey, sound like you were going to say something?
Yeah, we did away with the AV bridge, I don't know, 6 or 8 years ago. I think, at least in adult ECMO, I think modern ECMO is kind of the simpler the better. You take away the potential for clot formation and such. I think the reason that a lot of places, aside from weaning, I think the reason a lot of places had a bridge was to help oxygenator changeouts and such. And we just don't really see oxygenator changeouts like we did back in the old days with the big silicone rolled membranes and such. So I think there's a couple reasons for it, but again, I think the modern dogma is just keep your circuit as simple as possible.
Corey, you were around for those days with the silicone membranes and
I was around at the very end of.
It wasn't that long ago.
Yeah, come on.
here's one for the panel. Are any of you using prone positioning during ECMO in the ICU? Kind of like they do on ventilator patients.
We have on a couple patients. We really don't find many that we feel the need to try that on. What do you guys?
No, they talk about it. They say, you know, we're looking for a candidate. We might possibly do it one day, but the same as Desiree, we have not prone to patient in a long time on ECMO.
Likewise.
Nice. Desiree, I think when I first spoke with you, you had just presented a, what was it, like a 15-week ECMO run.
Yeah.
Here's one of the questions. What about cannula durability on long ECMO runs? Do you ever move to changing them out? I mean, I've actually heard of cannulas actually separating.
Yeah.
Yeah.
So we've had patients where they've had the same catheters for the entire run. So that patient that I had presented, they had the exact same cannula, same circuit for, I think that one was 13 weeks with no changes. But we've had other patients where sutures have eroded through cannulas over time, especially we had a central cannula where the suture in the heart was beating and it just rubbed on it. We've had cracked cannulas. I think most people who've done ECMO for long periods of time have gotten to that point. Usually when we're changing cannulas though, it's an indication. So either we have bacteremia, we cannot clear fungemia, or we just need a different cannulation strategy to support the patient.
Here's one. Do any of you have experience with clearing clots from cannula?
Yes.
Oh, really?
I think we all do. We all laughed.
What is the technique or your preferred technique?
So depending how stable the patient is or if they need any other intervention, on our pediatric side, our perfusionists do it. We just let the surgeons know. We will clamp off our circuit, separate the cannula, or we'll separate further down and add a new connector if needed, or replace an existing connector. Some people like to use the Fogarty catheters and then blow up the balloon and pull back to make sure it's completely cleared. If it is an acute clot, all of our ECMO specialists and perfusionists are trained to be able to do that no matter where it is, to clear a clot out if needed, to get the patient back on ECMO.
Very nice. We have time for one last question. Do you incorporate a manifold into your system? I guess for sampling or adding medications or CVVH? I guess that's beyond the scope of the cannulation topic, but if you have an answer for that, that'd be helpful.
We do not, in our adult patients, we try for all medications to go to the patient. If we have to, then we can do CVVH through the circuit, but it's not really, you know, we don't really like doing it. And if we have to, we do have pigtails, pre-oxygenator and post-oxygenator. So if we did have to hook up CVVH, we would pull post-oxygenator and try to return back to the patient or to the pre-oxygenator. In our pediatric population, we do have a manifold which goes in pre-oxygenator where all of their drips go into the manifold for pediatrics because they have limited access availability.
Very nice. We're just about at 8:59. There are many more questions which we do have recorded here, and we will send out answers as I mentioned. We're going to do a follow-up of the actual video and the discussion along with the questions and answers. I thank again everyone for joining. I thank the panelists for their time. A lot of work prior to that. Ken Smith-Buckland, Kate Maud, and Erin Butler for helping us put this together. New friend of mine, Joe Basha, giving me ideas on webinars. Thank you, Joe. So in closing, as a reminder, you'll need to complete a brief evaluation to claim your ABCP credits for the participation in this webinar. The link to the evaluation will be mailed to all participants after the conclusion of this. And again, please feel free to reach out to AmSECT at amsect.org, amsect@amsect.org. Should you have any other questions that may not have been asked during this webinar. Again, have a great evening. We will have more webinars to follow on ECMO ECLS. And thank you for joining us. Good night.